Hi there, my name is Mike Sullivan. I'm the Program Director of Valor Medical Services. I'd like to welcome you to this presentation from our series of continuing education for pre-hospital providers. Now, before we begin, there's a few things we need to go over. First off, the information presented in this program is intended for use by trained EMS providers. Also, due to variations in protocols and scope of practice among different states, departments, and agencies, this program may discuss or depict procedures, medications that are not acceptable in your daily use. If you see something in this presentation that varies from your agency's policy, always follow your department's protocols. Also, none of our authors or presenters of this program have any conflicts of interest or financial relationships they need to disclose. We do have documentation of this on file available in our office upon request. While we do our best to make sure that all the content we present is the most current available, participants are reminded that medicine is indeed a dynamic science and thus changes rapidly. So things may have changed since we've written or compiled this program. Please always follow the most up-to-date information available. In closing, if you have any questions about this or any of our other programs, please email us at info@valormed.net. Thank you very much and welcome to the program. Alrighty, now that we've got all that legal stuff out of the way, before we get started, let's talk about coffee for a second. If you're looking for a great cup of coffee, you probably want to check out coffeebrandcoffee.com. They're an online retailer, American owned and operated. They have a wide variety of coffees, teas, hot cocos, all sorts of different flavors. They've got all sorts of organic teas. You can get coffee in bean form, ground form, K-cups, whatever your heart desires. I've had several of the different blends and several of the different flavors. Absolutely fantastic. And because they are an American-owned small business, they don't have a big warehouse, so they don't have a big supermarket sales business. They roast it, they bag it, they ship it to you. It'll pretty much be some of the freshest stuff you'll ever get. Definitely highly recommend them. And they've got a promo code out for us now. If you use promo code VALOR SDS, you get a 5% discount off any order. So you can save a little money, try some fresh coffee, see what you like. They've always got different flavors coming through on their website. Some are permanent, some are limited time only. And if you look right there in the picture, you can see they've even got, yes, double caffeinated. Definitely a winner around this office. Alrighty, now let's get to class. Hi there, my name is Mike Sullivan, and I'm one of the instructors at Valor Medical Services. In this presentation, we'll be discussing endocrine emergencies and diabetes. Now, the National Registry 2016 edition outlines several core objectives we're going to discuss, and then we've added a couple more on top of that as well. First off, we're going to explain the role that glucose plays on the cells. We'll discuss the role of insulin in the body, identify some of the common symptoms associated with hypo and hyperglycemia. We'll identify prescribed medications used to treat diabetes, which may give us a clue into what's going on with a patient when we see these medications. We're going to discuss metabolic syndrome and how it comes on and what's involved with it. We'll also explain the management of hyper and hypoglycemia, and we'll talk a little bit about some of the functions of insulin pumps and how they work. And that's a topic all on its own that we can go in a lot deeper to. We're not really going to go too deep in this one, but we'll talk a little bit about them. Now, when we look at the numbers, there are over 34 million individuals in the U.S. who have been diagnosed with diabetes. That's about 10.5% of the population. So look around in the room. If you've got 20 people in a room, chances are you've got 2 people in there who have been diagnosed with diabetes, maybe more. In 2018, there were an estimated 1.5 million new cases diagnosed in adults, and that's typically going to be type 2 diabetes being that's diagnosed in adults. In 2016, a total of 16 million emergency department visits were reported, patients 18 and older that had diabetes listed as one of the diagnoses. Now, when we look at those 16 million visits, about 500,000 of them were for either high or low blood sugar. That's basically something that we can manage in the field to some extent as far as the low blood sugar. The high blood sugar, we can't manage that effectively, but that's something typically most patients manage at home. But what is diabetes? Well, let's go a little further. Typically, diabetes falls into one of two categories. It's either the body's inability to create and make its own insulin, or the body's inability to effectively use its own insulin that it does make. Either one of these is going to lead to the body failing to adequately metabolize and utilize glucose. We know we use glucose in all of our cells, so these patients need supplemental insulin or some type of medication, not only to help control their blood sugar, but to help get the glucose into the cells so it can be metabolized. Glucose in our body is a technical term for sugar. It provides the fuel that our cells need to run on and our body needs to function. Proper glucose levels ensure not only the brain functions, but also all the cells in our body function. Dramatic changes in glucose levels can result in erratic behavior due to changes in brain function. Also, we know that glucose levels are largely regulated by the pancreas and by the liver. Now, the pancreas plays one role in this. Its key job is to manage sugar levels using insulin and glycogen that works on a negative feedback system. Now, insulin is produced and stored in the islets of Langerhans, that's in the pancreas, and it's released in response to levels of high glucose in the blood and acts as a carrier or a key moderator for glucose to enter the cells. So if the body senses that the sugar is getting too high, it secretes more insulin. However, if it's getting too low, it should actually manage it back the other way. Now, as we look at excess glucose, it gets stored in the liver as glycogen. So if we have excess glucose in the system, it gets put away, saved for a rainy day. If blood sugar drops, the pancreas releases a hormone called glucagon. This glucagon stimulates the liver to break down the glycogen into the glucose and dump it into the system. So again, the pancreas monitors our blood sugar, and if it's too high, it will secrete insulin to make it metabolize more. If it's too low, it's going to secrete out the glucagon, causing the liver to release glucose into the system. Now, if something's not working with that, we have a problem, and that's where we get to the diabetic patient. This is a condition where insulin is either non-existent, it's minimal, or it's non-functional. Now, left untreated, this leads to elevated blood sugars. Now, two common versions of this condition, insulin-dependent diabetes, or IDDM, also known as type 1 or juvenile diabetes, typically characterized by a very early age of onset, and in this patient, the body, the pancreas specifically, does not produce enough insulin. So if it's not producing any insulin, the patient's going to need insulin shots or insulin administrations to make up for this shortage on behalf of their pancreas. The second one is the one we're seeing a lot more and more these days, non-insulin dependent diabetes. This is shorthand as NIDDM, or type 2 diabetes. This is typically associated with a later age of onset, may be related to obesity, and may resolve with weight loss. These cells are less receptive to insulin, so therefore, due to it that not using insulin effectively, even if the body's producing it, it's not doing enough, so we have to take a medication to assist the body in utilizing its insulin to make the cells more receptive to it. Now, non-insulin dependent diabetes, again, typically diagnosed later in life and may resolve. Type 1 diabetes, usually not going to resolve. These patients have been diagnosed at a very early age and they manage their insulin and their blood sugar fairly well. A lot of times they've grown up doing it and they're real experts at the whole thing. Now, some of the common medications we may see prescribed for non-insulin dependent diabetes or type 2, metformin is one of the most common. It may be out under the brand names of Glucophage, Glemzeta, Fortimet. Another one we see there is chlorpramide or Diabinase. Another one we may see is Glyburide, also marketed under the names Diabeta and Glinase. And I bring these up just to give you a little bit of an idea. When you see one of these medications, that's going to let you know that the patient likely is a type 2 diabetic, and they may well, be having a sugar-related problem. That we know by these medications being prescribed to them, they've got some type of sugar-related or endocrine-related intolerance. Now, some type 2 diabetes patients will also take insulin to assist in management of their blood sugar. Some of them find it more simple to deal with this. They may actually use insulin as an adjunct to help with sugar control, especially if they have to have difficulty managing their diet. Now, when we talk about diabetic-related emergencies, one of the most common ones we'll see in the pre-hospital environment is hypoglycemia. Now, depending what book you read, here we cite 45 to 60 or less than 45 to 60 was from Emergency Care in the Streets, 8th edition. I've also seen under 70. Any of these patients, typically they'll present with a very sudden, rapid onset. They were fine 30 minutes ago and all of a sudden something's not right. This can lead to changes in mental status, confusion. They can become diaphoretic or sweaty. They may become hungry, may have elevated heart rate because, again, the body's trying to compensate. It realizes it's not getting enough fuel, and then sometimes that tachycardia can actually help pull the sugar down further, only creating more of a problem. We may see rapid, shallow respirations. Very commonly, we'll see bizarre behaviors. Again, sudden onset, they were fine 30 minutes ago, and now something's wrong, and it's very wrong. The patient's acting very abnormally for them. If allowed to keep going down, this will potentially lead to seizures, as well as potentially compromise of other neurologic functions, and may end up with mild brain damage as a result of the sugar getting too low. Fortunately, this is fairly easy for responders to manage. When we look at the management of hypoglycemia, we always start with our scene safe and our primary assessment. We check airway, breathing, circulation, make sure the patient's got the ability to protect the airway and swallow. If they have an attached insulin delivery device, such as a pump, we hope that they can deactivate it for us. If they're unable to deactivate it, we may have to either deactivate or disconnect it. We can administer various medications as appropriate. And if the patient is conscious, still talking to us, we may go with oral glucose. If we don't have that immediately available, some type of sugary drink or soda, non-diet of course, something with sugar in it. We know their blood sugar is low, and therefore we need to do something to put more sugar in the system while we figure out what caused it to get low. Yes, finding the cause is important, but first things first, let's get their sugar back up, and that way they can potentially help us in determining what's wrong. If the patient's unable to swallow or we don't have oral glucose available, two of the other options would be glucagon, which we can administer intramuscularly, or dextrose, and we'll talk about those and dosing. Ideally, we provide supportive care while we take steps to get the patient's blood sugar back up. Now, oral glucose is packed in little tubes. Typically, it's somewhere between 15 to 30 grams of glucose per tube. It's fairly well accepted by most patients. I know some patients actually prefer different flavors. Yes, this comes in various flavors. The one there in the picture is grape. I've seen strawberry. I've seen lemon. I know some of our patients seem to like cherry a lot more. Again, it's fairly easy to use, and it can be carried almost anywhere with the patient. Many diabetics will actually carry 1 or 2 tubes of this in their pocket, just in case they realize something's wrong and their sugar's getting low, and therefore they'll be able to self-rescue or self-administer prior to losing consciousness or prior to getting further down the rabbit hole. One of the nice parts about using this is there are very little, if any, side effects and little, if any, contraindications to using it, so we can pretty much do it with fairly good feeling as far as what's going on. We're not going to do any further harm or do anything that's going to hurt a patient. Now, one of the most common medications we use is Dextrose, or D50. It's supplied in various packaging, different concentrations. I've seen D10, D25. In many cases, you may actually have D50 in a dextrose prefill on the truck with 25 grams of dextrose and 50 mLs of fluid, 0.5 grams per ml, and we may have to dilute it down with saline. We can make D50 down to D25. We can make D50 down to D10 if we need to, for either geriatric or neonatal patients. Now, the steps to doing this are pretty simple. If we're trying to make D50 into D25, we go ahead and we take the syringe there. Now in these pictures we colored it to make it a little bit easier to see. You won't actually have blue liquid in the syringe on a real one. However, we made it a little bit easier to see the concentrations. We take and we'll take the full 50 ml syringe and we will expel 25 mLs of the fluid from it. Now we want to expel that either into a trash can or someplace, because it gets very sticky and can actually be very messy to deal with. So we'll expel the 25 mLs of fluid, so we're down to 12.5 grams in 25 mLs. Now that syringe on the bottom left is still D50. It's just less D50 than there was on the top left. But when we draw up 25 ml saline from a bag and we mix it up, we now have made it D25. D25 has 12.5 grams of active ingredient, the dextrose, in 50 mLs of fluid. And this not only makes the medication more gentle on the patient's vasculature, it can make it easier to push if you have an extremely small vein, because we're having to push it IV. We can do this, water it down a little bit, dilute it, and it is more gentle on the patient's system. In most cases, using D25 will actually still adequately raise up the patient's blood sugar. Our whole goal is not to get them up to 120 or 180 or 200. Our goal is to get them to the point that they're conscious and they can eat something. Now, if you're dealing with a neonatal patient or an extremely small pediatric patient, you may need to mix it down to D10. Now, to mix D50 into D10, we'll go through and we will expel 40 mLs of the fluid, thus leaving us 5 grams of dextrose left in the 10 mLs of fluid. Now, on the bottom left, again, that's still D50, it's just a much smaller amount of D50. However, when we draw up 40 mLs of the bag to make up the volume of the syringe, that would give us a total of 50 mLs, but only 5 grams, thus it's D10, or 10%. This D10 is actually, again, going to be more gentle on the patient's system. Ideally, it's going to get their sugar up enough, and that way they'll be able to eat something. These can be done either with, again, to D25 or to D10. A good way to remember both of these, if you look at you're trying to get to D25, we expel to where we only have 25 mLs left, and then fill it back up. If we're trying to make it down to D10, we expel to where we only have 10 mLs left, and then draw it back up to the full 50 cc's. That way, again, good way to remember it. This can be done very easily in the field and has been done by providers for years to try to make the dextrose either flow into a neonate or infant smaller line, or if you're dealing again with a very small or geriatric patient and they don't need the whole 25 grams of dextrose. Now, if we can't get an IV line or we don't have the ability to establish a line, the other option that we use in the field is glucagon. Now, glucagon is used, we administer it via IM. It's typically in a 2-vial pack or a syringe with a vial that we have to reconstitute. Either style can be designed to be used in the field. Either one will deliver 1 milligram of medication IM or may be administered via nasal atomization device. Now, in order to do this, we'll actually take the liquid from one vial and we'll inject it into the tablet or the solid in the other vial. Now, one thing that's interesting to note, when we're injecting the liquid into the vial of the other, into the vial with the tablet in it or the powder in it, we will be actually pressurizing that vial, and so we may have to actually draw some air out of that vial in order to make room for the addition of the liquid. We don't want the tab on that vial to become too pressurized, so therefore, again, we'll inject some liquid and then we'll pull some air pressure out. Inject a little liquid, pull some air pressure out. This not only helps mix it, but it also helps keep the pressure in the vial more consistent. Now, any one of the above is used for treating hypoglycemia or low blood sugar, but let's get into high blood sugar. Now, high blood sugar based on the book is over 200. I've seen over 250. I've seen over 300, depending which books you read. This is typically going to have a slower, more insidious onset. May have rapid, shallow breathing. Patients may have a sweet, fruity breath odor. However, it's not always noticeable, and a lot of times you'll see providers may or may not even smell it. Not everybody is going to detect those odors as quickly. However, they'll have dehydration, pale, warm, dry skin. They may be weak, may be nauseous or vomiting, rapid, weak pulses. They may have episodes of polyuria, polydyspnea. Polyuria is excessive urination, polydyspnea is excessive fluid intake, and polyphagia is excessive eating. Because of the fact that blood sugar is so high in the patient's bloodstream, it's also an indication that it's not getting very well into the cells. If it's not getting into the cells very quickly, the cells still think they're hungry, and so therefore it's telling the body to eat more. Now, the big thing to remember about this is it comes on a lot more slowly than does hypoglycemia. Another thing to remember is a patient with a sugar of, say, 50 or 60, if they start showing signs and symptoms, they tend to decompensate much more quickly and tend to deteriorate much more quickly. The difference between a patient with a sugar of 200, 250, or even 300, yes, they need to go to the hospital. Yes, they need to be seen. However, it's usually not going to produce as dramatic a situation as low blood sugar does. Now, managing hyperglycemia is fairly simple. Of course, start with our primary assessment, airway, breathing, circulation, determine blood glucose level if possible. Yes, I've seen patients with 6s and 7s, 800s. Largely, our care is going to be supportive care. The sugar needs to be lowered. However, typically it's going to be done in the ICU due to the fact that the lowering of the sugar so rapidly is going to cause potential electrolyte imbalances, potassium depletion, and other things. So in the field, what we'll deal with initially, a lot of times, is fluid management. Our fluid management is focused on supporting ABCs and preventing dehydration. You may have a bolus of 15 to 20 mLs per kg per hour during the first hour. To put that in perspective, if we take our 220-pound ideal patient that weighs 100 kilograms, we're looking at, 1,500 to 2,000 ml bolus per hour in the first hour. This is largely because we're trying to not only dilute some of the blood sugar, but also with the way it begins, we know the patients are likely going to be dehydrated from the polyuria due to the urine system trying to excrete the excess sugar and filter it out. Therefore, anything we can do to help prevent dehydration is going to make the patient condition better. When we're looking at insulin pumps, these are one of the newest things on the market these days. They've become very common over the last 10 years. They may look like a pager or a smartphone. A lot of them are designed to secrete short-acting insulin over the course of 24 hours based on their programming. They set up what's known as a basal rate. This continuous administration really eliminates the need for long-acting insulins. Many of them are attached to the patient by way of a subcutaneous catheter. It almost looks like a pager on their belt with a short, clear section that goes up into their clothing and may attach to the side of their stomach or to the back of their arm. Typically, if we're dealing with a patient with low blood sugar, we need to try to either suspend or disconnect the pump when treating a patient. It's going to depend on what we know about the machines. Please be very careful on trying to manipulate these due to the fact there are many brands, and therefore it can be very difficult for us to work with. Now, one of the newer tools that many diabetics are using in their arsenal to control their blood sugar is CGM, or continuous glucose monitoring units. Now, these units may look about the size of a quarter or $50, maybe a little bit bigger. They actually measure the interstitial glucose with a subcutaneous sensor and transmit that information over to the insulin pump or other display device. Many of them will actually transmit to the patient's phone, and in some cases, some of the models will actually sound an alarm on the phone if the glucose falls below a certain level, especially if, say, the patient is sleeping or they're busy at work. They may get an alarm on their phone, hey, your sugar's down below this level, you may need to address it. Now, these can also contact a third party or a trusted friend to actually have them respond and assist the patient. Now, these units can be very, very helpful and help the patient as far as not having to check their sugar several times a day. However, in an emergent situation, sometimes they've proven to be less than reliable. So in an emergent situation, we should still be monitoring using capillary or whole blood, using our machines or a machine that we're familiar with, rather than trying to work on something that we're typically not familiar with. Now, when we look at what is metabolic syndrome, this represents a group of risk factors for not only coronary artery disease, but also stroke and type 2 diabetes as well. First one is central obesity, extra weight carried around the middle and the upper parts of the body. The patient may be described as having apple shape or something along those lines. Their body may become insulin resistant, thus using insulin less effectively than normal, may need supplemental insulin to help control blood sugar levels. We'd see this with our type 2 diabetes. May have blood sugar, fat levels, may be harder to control, may rise precipitously. This can lead to long-term risk for developing heart disease, type 2 diabetes, stroke, kidney failure, or poor blood supply to lower extremities. Therefore, when these patients typically will try to be put on a diet, try to do something not only to control their sugar, but also control their weight as well. Possibly weight loss can lead to, some improvement of this. Another condition we look at is adrenal hypoplasia. Now, this is a condition where it's a failure of the adrenal glands to produce and secrete adequate amounts of certain steroid hormones, including cortisol and aldosterone. Now, there's different causes for the condition. The three most common are congenital adrenal hypoplasia, which is basically they were born this way. It was a birth issue. Therefore, this inadequate control, they may actually be managing it long term. May also be as a result of Addison's disease or Waterhouse-Friderichsen syndrome. You may see those as patient diagnosis, and again, may give you a little clue to what's going on. Regardless of why they've got this condition, the condition can present with life-threatening adrenal crisis, also hypoglycemia, and hypotension. So if you're faced with a patient with adrenal hypoplasia, management would include fluid boluses for hypotension, dextrose administration to maintain blood sugar, and definitely transport to the ED. Again, we may or may not know what the patient's condition is. However, if you hear these terms, be familiar with them. Now, the patients may actually have an emergency kit that contains syringes of either hydrocortisone, 100 milligrams, or dextromethasone, typically both self-administered. However, a patient may need assistance in preparing them. Either one of these can be prepared either IV or IM, and again, patients with long-term disease are going to be better at managing it a lot of times than we are. In closing, we know that diabetic emergencies are one of the most common calls that we as providers are going to respond to. With the growth of our population, we're going to see more and more diabetic patients on a regular basis. Considering this, it's important that we not only take time to become more familiar with it as a disease process, but also learn more about some of the best practices to treat it and how we can help patients manage their sugar more effectively. We also need to be aware of the many high-tech devices that are coming out now. Patients are using at home to help manage their sugar and treat their disease. This, again, will be something that we're going to see more and more of, and the more aware of it we are, the better we can interface and work with our practice with those. Hey there, I'd like to thank you all for stopping by, checking out our video. If you want more information about our company or any of the stuff we do, you can check out our website. If you need EMS continuing education hours, we do have our online education platform posted up there. Also, we have our email address if you have any questions. You can find us on YouTube, Facebook, Twitter, and Rumble. We maintain channels on all of those. Also, please like, share this out to your friends, subscribe, help support the channel, and we'll keep putting more videos out there for you. Oh well, enough about that. I know what I'm up for. Time for a cup of coffee. Y'all have a great day. Be safe out there. Bye.